coming out in conversation is the whole idea of movement screens. For example, we just demonstrated the modified thoracolumbar fascia movement screen in order to try to see if there's restriction between the gluteus maximus and the contralateral latissimus dorsi. Now, the thing about movement screens is that it's simply a screen. Movement screen does not lead you to any diagnosis, but what happens a lot of the times is when people read about these movement screens, they look at what the author wrote as the predetermined cause of the problem, and then they kind of point at that as being the diagnosis, and they go ahead and treat. So, for example, when we were doing that modified thoracolumbar fascia test, when we have the person cross the leg in order to lengthen that gluteus maximus on the one side and rotate towards the ipsilateral side, hence lengthening the latissimus dorsi. What we're looking for is the finding that there's less rotation. That's all it tells you. There's less rotation. It does not tell you that there's fibrosis between the latissimus dorsi and the contralateral gluteus maximus. All it tells you is that there is a particular movement block occurring. It's your job using palpation to determine what the movement block is being caused by. Hence, you have to utilize your tissue tension technique and your palpation of spinal play and joint motion. So just because somebody has a finding with a movement screen, it doesn't tell you, once again, it's like an orthopedic test. An orthopedic test tells you the general area of where the problem is occurring or where the pathology is, but it does not help you with your treatment. A movement screen will give you a certain problem they have with the movement or a movement block, and then it's still your job to go in and palpate that person to find out what the problem is. The same with the overhead squat test. If they go with their arms up and they go to squat down and they lean forward, it does not automatically mean they have psoas tightness. It doesn't mean that they have decreased extension of their mid-thoracic spine. If their ankle or their calcaneus pop up, it doesn't mean they have tightness in their triceps surae group. There's thousands of different things that can cause all of those findings. Okay? Similarly, when I always talk about people who assess gait and assess running gait. We talked about this at the last F.A.P seminar. A lot of people watch people run when they're fresh, like they're not fatigued at all. They just get people to run down the hallway. And then they stand there and they look at the person's gait, and then whoever's running the seminar will ask everyone, what do you guys see? And it doesn't matter what everyone else sees because he'll say no. It's the left intertransverse area. I mean, come on. How can you possibly see that from somebody running from here to there? A lot of the times when somebody has a funny running gait, it's because they just learned to run funny. So when someone's running and their arm is wailing out to the side, a lot of the times I'll just say, like, can you not do that? And they'll be like, sure. And then I charge them for it because I just did, that's a good treatment. But I mean, number one, to watch someone run fresh, how many people here are runners that have injury? Anybody? When you're a runner that has injury, you very rarely feel that injury when you start running. You feel that injury 5-10K into the run. So if anything, if you want to assess someone's gait, assess how they look 5 or 10K into the run after they've been fatigued. When someone's fresh, everyone can mimic a great running gait. If you watch me run from here to there, I will look like Ben freaking Johnson. But if you watch me after 10K, I will be crawling along the floor because I'll be exhausted. So the whole idea of looking at movement screens and looking at gait and looking at people run is all fine and dandy. But you have to remember that fatigue plays a huge role. The conditions of the ground plays a huge role. The person's mood plays a huge role. And the person's habitual problems also play a big role. And if you just tell them to correct them, often they can't. So don't read too much into these movement pattern problems and looking at people move because it's so variable. And the main thing is if you do find a movement pattern problem, if you're watching one of your athletes play, number one, see if the coach can correct it by just teaching them to do it differently. And number two, don't assume a diagnosis based on what you see. You still have to go ahead and assess that person with palpation.